very for this nice presentation. The next speaker will be Dr. Rola Musa from Zagazig University. She will speak about rectal cancer MRI, local staging, and recent advances.
ما ينفعش تكون هي قدام السلايدز وبعدين تبقى موجودة هنا، لازم تكون كده صح؟ زي عارف نمبر اوف سلايدز رايت تو ليفت ولا من ده؟
ماشي عادي
اوكي شكرا. Yeah, hello. So our session today will be on rectal cancer MRI, local staging and recent advances. By Rola Musa from Zagazig University Hospital. Background: colorectal cancer is the third most common cancer in men and the second most common one in women. In the United States, it represents the third leading cause of cancer-related deaths in both men and women. Although the prevalence is considerably higher in more developed countries than in less developed, the mortality rate is lower, reflecting the increased screening and improvement in rectal cancer staging and treatment. The prognosis of rectal cancer is directly related to tumor infiltration into the mesorectum and the ability to surgically achieve negative circumferential resection margin, which is called the CRM. The standard treatment in patients with MRI staged locally advanced rectal cancer is neoadjuvant chemotherapy, followed by total mesorectal extension, which is called the TMA. The TME. So rectal MRI may add value in patient care in various scenarios, like in primary staging, the preoperative settings, and also in restaging setting after treatment with neoadjuvant therapy. In this session, we will discuss the role of MRI in assessment of local staging with a schematic step-by-step approach to facilitate comprehension of the key features to address in rectal MRI radiological report. So, as a start, we will discuss the anatomic MRI features, the most important features to be aware of, that every radiologist should be aware of so he can report rectal cancer efficiently. Usually we use a high-resolution T2 weighted image and oblique axial views, sagittal and coronal views. So in axial images, we can evaluate the mesorectal fascia, which is the low fascia surrounding the mesorectum, the rectum and the mesorectal fat, and also the mesorectal fat with the asterisk, which contains the lymphatics and the lymph nodes. Also, we can differentiate the rectal wall layers, which is the mucosa, submucosa, and the muscle layer, which is an loss of flow signal. Also, it's important to know the site of the anterior peritoneal reflection, which forms like a seagull appearance or V-shaped reflection anterior to the rectum. In sagittal view, it's mostly important for dividing the tumor into the low rectum, mid rectum, or high. We can also, it's important to know the distance of the tumor from the anal verge, so we can define the site of the anal verge. There is some muscular sling called anorectal ring, which separates the rectum from the anal canal, so it's an important anatomical landmark. In coronal views, it's important to evaluate the internal sphincter, the external sphincter, and the intersphincteric groove. So, staging of rectal cancer with MRI. In the context of primary tumor staging, performing rectal MRI is important for evaluation of the tumor location and morphology, the T category, anal sphincter complex involvement, CRM status, involvement of the pelvic side walls, extramural vascular invasion, which is called EMVI, and the N category. So these features should be included in all rectal MRI reports. We will discuss these items in details. So first of all, location and morphology. It's crucial to describe the tumor location in terms of craniocaudal direction, which would be divided into lower rectal, middle, or upper rectum, and in circumferential plane with the clock face position. Also, it's important to describe the relation to the anterior peritoneal reflection, the distance from the inferior border of the tumor to the anal verge, and also the distance to the anorectal junction. So, the location of the tumor. It's also subdivided into low, middle, and higher, while the first 5 centimeters above the anal canal or above the anal verge would be the low, and the second 5 centimeters would be the mid, and the third 5 centimeters would be of high tumor. While tumors located above 15 centimeters from the anal verge would be treated as cancer colon, and consequently their staging and treatment differ from rectal cancer. That's why it's important to report the exact location and distance from the anal verge. Regarding the morphological pattern, it's important to describe the tumor, whether it's polypoid, ulcerating, circumferential, or even semi-circumferential. It's also important to describe the morphology regarding if the tumor is of mucinous nature or non-mucinous, as the mucinous tumors are more aggressive and with poor prognosis. Usually mucinous tumors has more polypoidal appearance, and it's of high signal intensity in T2 rather than the non-mucinous ones, which may look of intermediate or low signal intensity. Regarding the T category is characterized by the depth of the tumor penetration into the rectal wall and the extramural spread into the mesorectum and adjacent structures. So it's important to identify the most invasive portion of the tumor corresponding to the area of the deepest infiltration, which is usually located either halfway in the craniocaudal direction, or it might be at the center of the C shape depicted in oblique views in the circumferential tumors. So in this diagram, to describe the tumor as T1 should be including the mucosa and extending into the submucosa, and to be a T2 tumor extending into the muscle layer, which is the muscularis propria, and if it's extending beneath the muscle layer, it would be T3. And according to the distance outside the muscle layer, it will be subdivided into A, B, C, and D. It's important to determine if this tumor is touching the mesorectal fascia or not. And of course, the T4 tumors would extend outside the mesorectum or the mesorectal fascia, T4A into the peritoneal cavity and touching the peritoneal reflections, and T4B if the tumor invades surrounding pelvic organ. So in low rectal cancer, And we should also comment on the anal sphincter complex status. Tumors in the lower rectum are in close proximity to the anal sphincter and are likely to invade the mesorectal fascia more than the mid and upper rectal tumors, owing to the narrowing of the mesorectum downwards. So the report should describe if the tumor invades the internal sphincter, the intersphincteric plane, the external sphincter, and also if it invades the levator ini. The coronal oblique plane is the best one to evaluate in T2 weighted image. So we have a tumor here which invades the internal and extending into the intersphincteric, and also it is including the levator ini muscle. The CRM status. So the CRM is the surface of the non-peritonized rectum that is resected during surgery. So it's important to identify that tumors arising in the part of the rectum that is not covered by the peritoneum. We only should comment on the CRM. MRI is the most reliable imaging modality to determine the potential CRM involvement. And the important of the CRM status is that it defines if there will be a recurrence of tumor after removal or not, and also it can be a good prognostic factor if it's not included. So to measure the CRM or to evaluate the CRM status, it can be obtained by measuring the shortest distance between the more penetrating part of the tumor and the mesorectal fascia, as I will show here. So this is the mesorectal fascia, and we can measure the most infiltrative part of the tumor. The distance between it and the mesorectal fascia would be the CRM. It's accepted to be till 2 millimeters. If the tumor is within 1 millimeter, we consider it positive MRF, and we also should report or comment on if the face time position of this infiltrative margin. So a tumor MRF distance more than 1 millimeter is a reliable predictor for negative margin. On the other hand, a positive CRM is the most important predictor for local recurrence and poor survival, as I said. Therefore, every report should include the CRM status and the location of potential involvement in clock-based method. The pelvic, other pelvic organs and the pelvic side walls involvement. This would consider the tumor as a T4B. So if the tumor is extending to any of the other pelvic organs like the uterus, vagina, prostate, seminal vesicle, ureters, or even the presacral fascia, it would consider T4 treatment, which usually is a non-operable case. So extramural vascular invasion, it's an important thing to comment on because it can identify the invasion of the veins in the pelvis and the perirectal veins before the distant metastasis occur. So it's important to identify the veins surrounding the rectum. We can identify the infiltrated vein by either irregularity of the wall, like this vein, and also thickening of the vein itself. It appears more broadened or more thickened in diameter than other surrounding veins. And also the signal of the vein itself, it would lose its signified signal intensity and may be replaced by an intermediate signal, just like that of the tumor. The lymph node involvement, which represent the in category. So the presence, the number, and the precise location of suspicious lymph nodes should be reported. The proximity between the suspicious lymph nodes and the MRF, which is the mesorectal fascia, is also important to report only for surgical planning. However, it has been shown that it does not affect or confer poor prognosis in the same manner as the primary tumor and the CRM. So, to summarize, currently rectal MRI plays a key role in management of patients with rectal cancer and local staging. T2 weighted image in different planes and diffusion weighted images, and also the dynamic contrast study are the most valuable sequences in cancer rectum evaluation. So just to remember items that should be included in our reports: the tumor location and morphology, T category, the anus sphincter complex involvement, the CRM status, involvement of the pelvic side walls, extramural vascular invasion or the EMVI, and also the N category. Thank you.
Thanks, Dr. Rola, for the presentation.